Hi, my name is Connie Kofanis and you're watching the video on the 4-diopter Prism test. This test is very similar to the 20-diopter Prism reflex test that we've just discussed, except that you're using a far smaller prism, a 4-diopter, and in this instance we perform this test on individuals we suspect have a microstrabismus or a microtropia. We'll learn more about a microtropia later on, but essentially a microtropia is a small angle strabismus, generally of about 10 diopters or less. And there's a specific cohort of patients with microstrabismus who on cover test you don't observe a movement on cover. And so you're led to believe during the cover test that the patient is orthotropic, when indeed they have a microstrabismus. Now we'll talk more about why that's the case when we get to that topic, but for the purposes of learning about the 4-prism diopter test, it's worthwhile knowing that this is the cohort of patient we're most interested in, where we suspect there is an underlying small deviation that is not being picked up by the cover test. And the 4-prism diopter test is able to confirm the presence of a microtropia. Okay, now the 4-prism test is also known as the 4-prism diopter prism reflex test. So the terms are interchangeable in essence, and it's because the 4-diopter prism test is essentially using the same principle as the 20-diopter prism reflex test. Now the 20-diopter prism reflex test, with 20 diopters you're looking at a 10-degree eye movement. So obviously with a 4-degree prism reflex test you're looking at a 2-degree eye turn. Okay, the reason why we use a 4-diopter is because it is probably the smallest amount of prism where you can comfortably see the eye movement or reflex. So you don't want to go any less than 4 diopter, and you don't want to go any greater than 4 diopters, because what you're looking for is a microstrabismus. And in these patients, if you give them 20 diopters, they will generally pass the 20-diopter reflex test. So you have the potential of misdiagnosing a patient as being bifoveal using the 20-diopter. So this test is specifically looking for that small angle manifest strabismus. Okay, so what do we expect of a patient who is bifoveal and doesn't have a small angle strabismus? It's exactly the same as what we expect of a patient with a 20-diopter. So here I'm giving you an example of someone who is bifoveal, fovea to fovea, no strabismus. We put the base out prism, the image shifts towards the base, the eye moves in under the prism, the contralateral eye moves out, diplopia is recognised, and subsequently the eye moves in for bifoveal fixation and for BSV to be achieved. Okay, exactly the same. The only difference is that we're now going to see only 2 degrees of eye movement. Okay, so what do we expect of an abnormal response? Well, exactly the same as a patient with an abnormal response on the 20-diopter. So this means that if you put the prism in front of the deviating eye, you'll see no movement of that eye and no movement of the contralateral eye. If you put it in front of the fixing eye, you'll see a movement out of the deviating eye, but it won't return back in for BSV. Okay, standard response. But let's now talk about why it is that we don't see this movement. Well, one reason is because a patient may have a suppression scotoma. And so we see here, just as the example I gave you in the 20-diopter, that we have a small suppression scotoma. And the image here with the base out falls within the suppression scotoma, and therefore there's no movement of the eye, the deviating eye, and there's no movement of the other eye. Now if you put the prism in front of this eye, you would see this eye move in and this eye move out, but no return back. Now the reason you need to use a 4-diopter prism reflex test is because the suppression scotoma is small. You're looking at a microstrabismus, a strabismus of 10 diopters or less. So you need this prism to work within the suppression scotoma. If on the other hand you use a 20 diopter, the image will actually fall here on a temporal retina, and there will be recognition of diplopia, and therefore there will be a fusion response. A peripheral fusion response will occur because these patients with microstrabismus have the capacity of binocular single vision. It's just subnormal. Again, we'll go over that a little bit later in the topic on microstrabismus, but the 20 diopter, they will pass, the 4 diopter, they will fail. So it's important that you specifically use this prism. Okay, I want to go over one other thing. It is possible for a patient to fail the 4 diopter prism test and give you an abnormal response, but not have a suppression scotoma. Why? It has to do with Panem's fusional areas. Now remember, when you go back to your binocular vision notes, that we don't exactly have a point-to-point relationship. Corresponding points are not point-to-point. They're area to area. And in strabismus, or in microstrabismus, what can happen is the extension of Panem's fusional areas. So let's imagine that this little circle here represents the area, or the corresponding area that corresponds to another area over here. And we can see is that as we shift the image towards the base, it falls outside of Panem's fusional area, which means if there wasn't a suppression scotoma or the patient was actually indeed bifoveal, there'll be diplopia and a fusion response because you've stimulated non-corresponding points. You've come outside of the corresponding areas. Let's say, however, that the area has extended and now the image is shifted 2 degrees, but is shifting within the same area. Well, even if you don't have a suppression scotoma in this instance, there will be no recognition of diplopia or any need for any refixation movement to occur because there's been this extension of Panem's fusional areas. And as such, you will actually get no movement. You'll get what looks like a suppression response. So, this patient here will fail the 4 diopter due to extension of Panem's fusional area, and this patient here will fail because of suppression. Now, this is rather academic. In clinic, for instance, if a patient fails the 4 diopter prism test, I have confirmation that they have a microstrabismus. Now, whether I know that it is a suppression scotoma that is causing it, or whether it is Panem's fusional areas being extended that's caused it, is academic in nature. It won't change my treatment. But it's important to realise that there are patients who will have suppression and don't have suppression that is causing that failed response. If you wanted to go to the effort of trying to work out whether central suppression is present or not, and whether it's likely to be an increase in Panem's fusional areas, well, what you can do is do a test like Bagolini striated glasses test and ask if there's a missing gap in one of the lines. That will tell you whether there's central suppression. Or you can do Wurzfors lights using the macular torch, again looking for central suppression. So you can use a test that tells you a little bit more about the presence of central suppression, and if, for instance, they get a complete cross with no gaps in the cross, well, then it's likely to be an increase in Panem's fusional areas. But if the patient says that there's a missing part, well, then it's central suppression causing the problem. Okay, one more thing to know about the 4 diopter prism reflex test. It can, or patients can, give you atypical response. So for normal, like we said, we want in the eye, under the prism to move in, the eye, contralateral eye to move out and in. And then for abnormal responses, of course, we're looking for no movement of either eye if we put it in front of the deviating eye, or if we put it in front of the fixing eye, we'll get a movement in of that eye, the other eye moving out but not back in. Okay, we know those standard responses. Some patients, however, don't give us a standard response. And here's a list that has been put together of some of the abnormal responses that you see. And as an example, we have here, example 1, eye under prism moves in, fellow eye remains stationary. And the patient says that they notice diplopia. Now that's not normal. You're supposed to see a conjugate movement of the other eye. Okay, in these instances, you have an inconclusive diagnosis. You don't have a conclusive outcome of the 4-diopter confirming that the patient has a microtropia. And usually what I'll record in these instances that I performed the 4-diopter Prism test, and I'll indicate inconclusive, because you're not getting a normal response that indicates the patient has BSV, and you're not getting a response that indicates that the patient definitely has a microtropia. And some of your patients will give you this, so just know that you can get atypical responses, and it will remain up to your other investigations to determine whether this patient does or doesn't have a micro. Okay, finally recording, we indicate we've performed the 4-diopter Prism reflex test, so you could put PT there, and we indicate positive for a right microtropia. So here what it's saying is that it is the right eye that was deviating. So when you put it in front of the right eye didn't move, nor did the left eye. And when you put it in front of the left eye moved in and the right eye moved out but didn't come back. Okay, that's the response. Positive means it's a failed response. Negative means it was normal. If you didn't put negative for microtropia, you could put BSV response, which would again indicate that the patient has passed that test and a BSV response was noted. Okay, that brings us to the conclusion of this video. Thank you for watching.